Hello, I'm Dr. Manoj Malu and I welcome you to our deliberations on scabies. WHO added this important infection to the list of neglected tropical diseases in 2021 in the hope that this will bring attention, investment, and research into this important infection affecting nearly 300 million people globally and thousands of cases of scabies in the UK every year. The number of cases in the UK have rocketed since life normalized after COVID. But as this is not reportable or notifiable infection, we do not have accurate data on its true incidence. To look at this infection just in terms of the number of cases will be true tragedy. If we wish to comprehend the impact of the scabies, we have to delve into human suffering of individual cases. Today, our discussion will be structured as follows. First, we will explore why scabies is relevant today. Next, we will touch on the biology of the mite, Sarcoptes Scabiei variety hominis, and then we will look at how the biology of these mites influences clinical manifestations, limits current investigative methods, and poses challenges in effective treatment. This presentation also includes real life examples of three patients who sought treatment at Clarewell Clinics from our team within the last 12 months. First, we have Susan, a 45-year-old woman with a long history of scabies. Despite treatment at various clinics, she was worried about visiting her ailing mother, fearing she might pass the infection to her during her cancer treatment. Next, I saw a family of three Rachel, Peter, and shall we call little one Emma. They had been sleeping separately in separate rooms for many months and avoiding physical contact for 6 months due to concerns about scabies transmission. How painful, how more painful it can be. Then there is Indu, who had been avoiding contact with her husband and daughter and their dog for 4 months due to persistent itching. She believed she contracted scabies while working with a group of asylum seekers and was struggling emotionally with the idea of returning back to her work once, if and when she got better. Concern about treatment failure and build-up of hopelessness, and concern about getting reinfected and infecting loved ones are underlying themes in most patients we see. Such individual impact is hard to quantify and perhaps much more significant than better known social and institutional burdens of scabies. Lastly, let me tell you about a 26-year-old male, a really touching story. He noticed spots on his left arm just around Christmas, which gradually spread. He visited multiple clinics and received varying diagnoses: folliculitis, suspected scabies, confirmed not scabies, and uncertain diagnosis. He also visited several pharmacies, three ruled out scabies while one confirmed it. He underwent 3 rounds of permethrin treatment, which resulted in sore skin but slightly reduced itching. Working for a well-known music label, he was temporarily barred to prevent from work to prevent potential spread to high-profile artists he worked with. He had traveled to LA, New York, stayed with his girlfriend there, but none of his contacts developed symptoms. 4 weeks after his last permethrin treatment, he experienced, just when he thought everything is getting better, some new lumps, although not as much itchy as they used to be before, bit like post scabies syndrome. He requested a skin scraping to confirm the absence of scabies so that he could return to work without posing a risk to his colleagues. These cases highlight the profound impact scabies can have on individuals and their families, underscoring the importance of accurate diagnosis and effective treatment. Let's take a journey through the evolution of scabies, science, and treatment. Although scabies has been known for over 2 millennia, it was soon after the invention of the microscope in 1687 Sarcoptes Scabiei was identified as the mite responsible for scabies, making it one of the earliest examples of a true useful discovery with a microscope. Not much happened for almost 300 years until in 1950s, the invention of malathion, which provided the first truly effective treatment of scabies, followed by permethrin in 70s, which remained a first-line treatment option since then, as it was safer, less toxic, and more effective than malathion. In 1970s, Campbell and Omura independently discovered a new class of compounds called ivermectins that kill parasitic roundworms that causes infection like river blindness and lymphatic filariasis. The most potent of these was released into the market in 1981 as the drug ivermectin. This was truly and is truly a wonder drug in the class of penicillin and aspirin, if you like, which is now used extensively in agriculture, the veterinary world, and as a treatment of various parasitic infections, including its use in treatment of resistant cases of scabies. It's a pretty safe and effective medication, and if it did not find wider use earlier in the world of scabies, it was more to do with the prescribing habits of us doctors and guidelines that lack of evidence. Treating scabies is a resource, emotion, and time draining proposition today as it was in the 1940s, as you can see from this painting displayed at the Imperial War Museum here in London. A Greek orphanage where a child is being soaked in a sulfur based lotion, see the yellow color, by a nurse. Three other children await their turn, with two nursing assistants, two soldiers, and a priest waiting to lend a helping hand. This scene vividly captures the significant impact of scabies could have on institutions like orphanages, schools, prisons, and military units. It's harder to capture the mayhem in individual households when they're going through this ritual of applying the cream and cleaning the environment. Scabies has remained relevant in the background, producing pandemics every 15 to 20 years, but could not attract the rich world's attention for it did not have the fatality of HIV or the fear of flu viruses like COVID. Scabies remains a contemporary, serious, and a bit of a mystical infection. And if we want to understand this infection, we have to understand the biology of mites and try to correlate its behavior with what we see in our consulting rooms. The ideal habitat for scabies mites is a thick stratum corneum with minimal hair. The powerful front legs of mites help them stick well to the skin surface, while the proteolytic enzymes they secrete soften the keratin fibers in the stratum corneum, further helped by local immune reaction as well as physical destruction of the skin with itching. Mites burrow in the skin. Male mites are smaller in size and only need small holes to live for a couple of weeks before they die. Once they have impregnated the female mites, they don't have much to contribute really. Hair and hair follicles are important in influencing how the mites burrow. We do not like barriers in our path, nor do the mites. Where it can burrow in a straight line, it will do so. And if you see a linear burrow on the skin, where there is some obstruction, she bypasses it and will produce a zigzag burrow. Where there is not much freedom of movement, like in armpits and genitals, they remain local, burrow locally, and produce nodular lesions. The superficial habitat is ideal for the mites, allowing them a good balance of protection from external forces and reproductive advantage as the young mites can reach the skin surface as they grow towards their adulthood. This also has a bearing on our treatment strategies. Topical cream like permethrin must penetrate the epidermis and stay there in the stratum corneum for as long as possible to achieve the maximum effect. In reality, the permethrin gradually diffuses through avascular epidermis, that is, epidermis without blood vessels, into the vascular dermis. This is why having a hot shower before using the cream will reduce its effectiveness by increasing dermal blood flow and faster clearance of permethrin from the epidermis. 50% of the active ingredient is absorbed from the epidermis within the first 48 hours of application. Will a second application, 6 hours after initial application, bit like a staggered application, be more effective? Will increasing the contact period from current recommendation of 8 to 12 hours increase the effectiveness? I don't have the answer to these questions, but I have deployed these approaches in some patients in desperation with mixed benefit. On the other hand, ivermectin taken orally circulates through the bloodstream, diffuses from dermal vasculature into the outermost layer of epidermis. That's not the most efficient way to get higher concentration of active drug where it matters most. That is stratum corneum, where the mites are lying and reproducing. I suspect many cases of treatment failures are due to our inability to get enough medication at right place for adequate duration rather than true drug resistance. The life cycle of the scabies mites progresses through four stages: eggs, larvae, nymphs, and adults, hence the acronym ELNA. The journey on a new human host starts when they have picked up the mites from another infected person or coming in contact with infected items around everyday life. Eggs, larvae, and nymphs do not produce successful infection. It has to be a pregnant female mite or an adult female mite in company of a courting adult male ready to become pregnant. Pregnant female mites have all the responsibility on their shoulders. She burrows underneath the skin, parallel to the skin surface in the stratum corneum. She lays 2 to 3 eggs every day inside the burrow, crawls in any direction it can feel safe. You know the instinct of a pregnant mother. In a few days, the eggs develop into larvae, which molts into a nymph, which goes through the successive molting to become either an adult male or a female. While some of the young adult mites, males as well as females, will be successful in finding their way to the surface and find a willing mite to mate and carry on the life's journey. Others will not be so lucky. It's a bit like a race of a survival where some escape to tell the tale, others get lost in the dark burrows, and the promises come to an end. Adult female mite typically survives for 6 to 8 weeks, keeps laying eggs till her last day, till her last breath, and dies in the deep end of the burrow, while the next generation of pregnant mites are trying to get into either the local burrows or new burrows in other skin areas of the host, far and wide. Scabies primarily spreads through direct skin to skin contact, which can occur in social, sporting, or workplace contacts. When the nature of the initial contact is sexual, the initial lesions may appear in the genitalia. Transmission can easily occur with hands and wrists to the genitalia and sleep, a common posture adopted during sleep. It can also be transmitted from infested surfaces like door handles as well as the seating surfaces in public transport. New popular workplace practices like hot desking could further escalate the risk of transmission, where many colleagues share the chair and worktop in a day or over a few days. Our hygiene habits are as unique as each one of us are and are truly first line barrier the mites encounter. As we have mentioned earlier, the presence of hair and hairy follicles presents formidable difficulties for mites. This is why scalp and beard areas, and to a lesser degree armpits and genitalia, are not the most popular places for mites to put their tents. This indeed is the rationale behind the advice to apply scabies cream below the chin in adults, but not so in children. While previous exposure to scabies can produce immunological memory and symptoms can arise within hours and days rather than weeks, typically it takes 4 to 8 weeks uh, after exposure to get the beginning of the symptoms. Host response of scratching spreads them to other parts of the body. Nail beds should be most carefully treated area with the cream because that's where huge number of mites uh, find a lodge. In clinical settings, the use of popular wipes like Clinell with antibacterial and antiviral activity offers no specific protection from scabies mites. And to be honest, there are no commercially available anti-scabies wipes, uh, even when you have a visit from somebody in your consulting room known to have scabies. Scabies is a difficult diagnosis to consider and a simple one to make. Suspicion rather than confirmation should be the basis for treatment. Symptoms of scabies are simple: itch or rash or both. They typically start within 4 to 6 weeks of initial infection, unless there had been previous infection, as you see in endemic areas where symptoms can begin within hours. Itching can be intense and worse at night, disturbing the sleep. It doesn't make sense to the patient, and often they hope that it will get better, but it gets progressively worse. Some get accustomed to the itching, while others go crazy with it. Generally, children cope with the itching better than adults. Itching can initially be localized to the area of initial infection, like hands or genitalia, in some patients, but soon spreads more widely. Often, patients have tried over the counter creams and antihistamines before seeking medical advice. Rash in scabies is primarily as a result of an allergic response to mites and their fecal excreta, but in part due to the enzymatic and physical damage to the skin and by mites. This gets further compounded by use of various creams recommended by friends, well-wishers, and clinicians. The classical lesion is a burrow, and the burrows can be of all sizes and shapes. The appearance of a burrow is often misunderstood amongst clinicians. All that the word burrow means is that this is the hole in the skin that a mite is trying to or already has produced, and in the course of time, despite facing all the barriers and difficulties, it will try to survive there and make a home of some sort. There are no architects involved and no planning permission is needed. So it will make burrows which you can describe as a small pimple, papules, nodules, or even blisters, looking easily like herpes simplex infection. This is when mites have not had time or opportunity to go on long distance tracking. When it goes on long excursions, it will produce linear burrows. On careful examination, will have a hint of zigzag pattern to them. Mites don't travel in a straight line. If you see a straight line mark, it's probably not from scabies but from scratches. Notes on rope appearance is a popular description where there are lesions within normal skin left in between the lesions. Persistent symptoms like these over weeks or months should raise suspicion of scabies, even if they don't appear to be classical. The suspicion becomes stronger if others in the same household, school, or workplace report similar symptoms. But remember, many will never develop symptoms, and those who do may do so weeks or months apart. Risk factors such as recent travel or holiday or visitors are helpful. There are four different areas of skin lesions on a patient seen recently on different days. And as you can see, on the leftmost, there are clear linear burrows. In the second one from the left, a rash around the elbows, and then hands and finger webs. On the rightmost, details are not as clear at first glance, but upon closer examination, one can see the lesions clearly. All of these lesions are examples of burrows. Remember, burrows don't need to have a length. The classic distribution of scabies typically involves areas like armpits, flexor surfaces of elbows, wrists, finger web spaces, palms, soles, and less commonly, the genitalia. Lesions may also appear on the chest, under the breast, on the buttocks, and behind the knees. All these are areas with a thick layer of stratum corneum and minimal hair. It's crucial to apply cream when you're treating scabies very meticulously in these areas. This patient, an Asian man with a rather pale complexion, presented with a penile ulcer and lesions on his palms and he was concerned that he had syphilis. You can notice multiple nodular lesions on the scrotum and some burrows on the finger webs and lesions on the palms. Clinically, it was scabies, and syphilis was ruled out with appropriate tests. Of course, one can have scabies and syphilis as dual infection. On darker skin, scabies lesions can be challenging to detect, often requiring a diagnosis based more on the history of itching than the visible signs of scabies. Classical scabies, characterized by clear symptoms and typical rash in terms of burrows and their distribution, are often linked with travel and reports of close contacts having symptoms suggestive of scabies. However, symptoms can vary widely from mild irritation to severe lesions, making diagnosis challenging and easy to miss. The key to consider is the possibility of scabies. Being aware of the possibility is halfway to making the correct diagnosis. Early in infections, lesions often appear where contact occurs. For instance, lesions from playground exposure first appears on the hands, fingers, and wrists, while sexual transmission might show lesions primarily on the genitalia. Changing postures during sleep allows us to scratch different parts of our body and facilitates the spread of mites between hands and genitalia, for example. Lastly, crusted scabies or Norwegian scabies is a chronic infection, and this results from an eruption of vesicles, secondary infection, and crusting, harboring millions of mites, making it extremely contagious and potentially fatal. It's a medical emergency and should be treated as such. There is no often underlying severe nutritional or immune deficiency in such patients. Such a diagnosis is also a public health crisis. Eczema is a common skin reaction to all types of stimuli and irritants, especially in those with an atopic tendency, like having atopic dermatitis, asthma. Sometimes scabies can serve as one such irritant and produce new onset eczema, which can be localized or widespread, rather than like a typical scabies rash. Similarly, scabies can worsen pre existing eczema. Scabies mite can also provoke secondary bacterial infections. These are common presentations of scabies, especially in children in the developing world, often treated as skin infections, and underlying scabies is missed. Actually, impetigo and pyoderma on one side and scabies on the other side are two sides of a public health coin. That's why in many countries they undertake mass treatment of communities with azithromycin and ivermectin. Here we have a case with penile blisters suggestive of genital herpes. However, upon examining the fingers, you can see typical lesions of scabies between the finger webs. Blistering lesions can be seen not only with herpes, and in this case, bullous scabies, but also with other skin conditions, for example, pemphigoid and acute lichen sclerosis, and with drug eruption. In the West, with a good level of nutrition and generally good access to healthcare, serious complications of scabies do not spring to our minds. Short term serious consequences like disturbed sleep and effect on mental health are well recognized. Skin infections like pyoderma, impetigo, cellulitis, and in severe cases, necrotizing soft tissue infections, and rarely septicemia or other serious complications. However, more serious are long term silent consequences as a result of complex immune phenomenon against streptococcal and staphylococcal bacteria, resulting in presence of blood, technically called hematuria, acute kidney failure, and chronic renal failure due to post streptococcal glomerulonephritis. In the developing world, a significant portion of acute and chronic renal failures are linked to underlying skin conditions like scabies. Extending on the same theme, there are studies to suggest that scabies can be associated with some autoimmune conditions, and they suggested that there's a weak link between scabies and pernicious anemia. A discussion of scabies cannot be complete without some attention to bed bugs. Bedbugs are caused by arthropods like Cymex lecticularis, Cymex hemipterus. Unlike scabies mites, bedbugs are visible to the naked eye and have a longer lifespan of about 95 to 100 days compared to the 6 to 8 feet that adult scabies mites live. The female adult scabies mites live. Bedbugs reside in mattresses, sheets, and clothing. That's how they're mainly transmitted rather than skin to skin contact that we see with scabies. Bedbugs require human blood to feed on to progress in their life cycle. Hence, you will see the blood stains on items of clothing with bedbugs, not with scabies. Symptoms of bedbugs can appear within minutes to days, unlike scabies, where symptoms generally take many weeks to start. Diagnosis of scabies is primarily clinical, and this is sufficiently accurate for classical scabies. However, most cases of scabies are ordinary. That means they do not fit the classical criteria, and perhaps many where presentation is with eczema or skin infections like impetigo, folliculitis, and pyoderma. In such cases, diagnosis of scabies is missed initially, sometimes made late, and sadly, sometimes never made. The diagnostic methods for scabies are very 19th century, and the only way forward is molecular diagnostics with PCR, which has not yet been made to the clinical practice, but I believe not very far. Self suspicion and self diagnosis of scabies by patients is common and should be respectfully considered by us clinicians rather than miss the opportunity to make a timely diagnosis. Microscopy of skin scrapings remains the gold standard with about 90% specificity and sensitivity being much lower, about 60%. The process involves taking samples from the lesions and examining them under a microscope, which can be decisive in confirming the diagnosis of scabies. Microscopy is more accessible in the tropical and developing world than in many first world countries. It's in part due to services not being used to do the skin scrapings microscopy, and in part that's due to stringent compliance requirements in terms of quality control. Scraping should be superficial, as scabies mites live just beneath the top layer of the skin. If blood appears during scrapings, you have scraped too deeply. Precisely locating the burrow can be difficult sometimes, so it's best to scrape from multiple angles and in different directions. Skin scrapings are helpful when trying to differentiate persistent scabies, whether it's from treatment failure or reinfection from post scabies syndrome. You will uh, find mites or the Shibella with ongoing infection, but not so with post scabies syndrome. We will be adding a video at the end of this presentation on various aspects of taking good quality skin scrapings. Wood's lamp is inexpensive equipment and easy to learn using it. It emits ultraviolet light at 365 nanometers, allowing detailed examination of the skin. Under this light, or I would rather say invisible light, you can see a bluish whitish background with whiter curvilinear burrows indicative of scabies. For an effective ultraviolet examination, you need three things: a dark room, which is not always available, in which case you can convert your consulting room into a dark room by drawing the curtains and switching off the lights. You will need a patient who is willing to be examined in a dark room, as some patients, especially women, may have some concern about their personal safety being examined in this manner. And it's not easy for a clinician to examine the dark room either, particularly when there is some risk of getting the infection from the patient and possibly a higher risk of allegation of inappropriate physical contact with the patient. Dermatoscopes are very popular with dermatologists These devices have a short focus length and can be applied directly to skin lesions, displaying images either through the lens itself or on a computer screen. They offer various magnifications revealing clinical signs of scabies. In this picture, you can see how the burrows resemble jet contrails and a delta sign. Many other appearances have been described, and you have to remember these are signs suggestive of scabies rather than confirmation of scabies. The other challenge is how you clean the devices between the different patients, as the standard wipes do not kill the mites. You may wonder if you can do a dermatoscopy with a smartphone. The answer is no, as dermatoscopes have super low focal lengths for close examination, while smartphones are designed to take images from a distance. You may also wonder if you can do a microscopy of your skin scrapings at home with your smartphone. The answer is no. You need stable 40x magnification to see the mites and their eggs. Smartphones will give you unsteady 10x. Both skin scraping and superficial biopsies for histopathological examination can provide the most accurate and detailed study of suspected lesions, especially when the lesions are atypical or the diagnosis is uncertain. This method identifies all stages of scabies mites and their fecal matter and reveals associated pathological changes that you may see in epidermis and dermis from infection and immune reactions. So in this slide, you can see a nodular scabies lesion in the stratum corneum along with scabies mites and excoriations. It's not used routinely as investigation. It's invasive, expensive, and needs specialist skills for taking samples as well as for pathological examination. As traditional microbiological tests are being replaced with molecular diagnostics for their accuracy and efficiency, DNA PCR for scabies shows great promise as the most sensitive and specific test available. Currently, there is no commercially available PCR test for scabies, although recent trials like one amplifying ITS2 gene have shown very high sensitivity and specificity. The main challenge in various studies looking at PCR based assays in the past has been in difficulty obtaining high quality screen scrapings for testing rather than the accuracy of the test itself. Given the clinical need for a good diagnostic method for scabies is so acute, we expect DNA tests to be part of a clinician's armamentarium in the foreseeable future. Whilst we are focused on scabies specific tests, it's important to consider the role of basic tests like a full blood count and a CRP test for blood markers of allergy, inflammation, and infection, which can indicate secondary infections that require treatment, rule out diabetes and HIV, and undertake blood skin swab cultures for skin infections. Scabies specific antibody tests are available, but they're seldom used in clinical practice as their use is mainly confined to epidemiological mapping. There had been some concern about around mites developing resistance against various creams and possibly ivermectin, but there are no tests available outside of research setting to study such mite resistance behavior. In this section, we will go through the principles of treating scabies, which essentially means treating the patient, treating their close contacts, and treating their immediate environment to prevent reinfection. The current state of scabies treatment is pretty unsatisfactory in terms of available treatment choices, access to services, as well as the advice and support available to the patients and their families. All available treatment options, whether topical or oral acaricides, act on motile stages of mites, larvae, nymphs, and adults. They don't work on the eggs. This is why there is a need to repeat the application or medication at an interval, usually 7 days, with the hope of killing new batches of larvae, nymphs, and adult mites that emerge. Permethrin 5% cream remains the first line medication and is considered to be more effective and less toxic than malathion or Durbac M. Oral ivermectin has recently become very popular and is likely to be the first line drug in the near future. In difficult cases, a combined approach of using both topical and oral medications at the same time can be used. Supporting treatments like generous amount of moisturizers are routinely advised, whilst 10 to 20% sulfur ointments, use of antihistamines, and topical steroids can be used in select cases based on the severity of the infection and the impact from the symptoms. Treating secondary bacterial infections proactively with oral antibiotics is another important consideration. Patients often struggle with itching, anxiety, as well as disturbed sleep, and use of sedating antihistamine like promethazine is a cheap, very effective, and safe for both children and adults. Patients often experience anxiety due to the abundance of online information and persistent symptoms. And even more, any perceived treatment failure can increase their anxiety manyfold. Therefore, strong follow up support and effective communication are essential. In addition, regarding the care of contacts, it's vital to treat them simultaneously and as if they're truly infected. So, this will be treated wholeheartedly. This thorough approach helps prevent the spread and recurrence of scabies. Although topical treatment is currently standard, oral treatment with ivermectin is the way forward. Applying cream can be challenging and requires strict adherence to the protocol. Permethrin 5% is the most popular treatment, whilst 1% solution is meant for head lice and is not suitable for scabies. To use permethrin 5%, cover the entire body, focusing on lesions, finger webs, palms, and soles. Don't forget the fingernails as well. Avoid applying immediately after a hot bath, as increased blood flow immediately after the hot bath can cause the cream to be absorbed too quickly and leave lower concentration of cream in the stratum corneum where they need to fight the mites. Often, more than one tube is necessary based on the body size. I always advise patients to keep some amount of cream for reapplication should they wash their hands during the treatment period. Permethrin is a vanishing cream and will disappear once it is rubbed in. About 50% is absorbed within 48 hours with a recommended contact time of 8 to 12 hours. Unlike malathion, where the recommended contact time is 24 hours. Permethrin is safe during use in pregnancy, unlike ivermectin. Before permethrin became widely available, malathion or Durbac M was the drug of choice for treating scabies. However, it's a toxic pesticide with carcinogenic concerns, more harmful than permethrin, and it has been banned in many countries, especially in the veterinary and agriculture sector. Malathion requires a longer contact time of 24 hours and has widespread mite resistance. Is very toxic to aquatic life and has long lasting effects, raising concerns about its safety on humans. Therefore, it should be avoided in scabies treatment whenever and wherever possible. Applying creams for scabies is no easy task. It requires a lot of planning in terms of fitting around one's individual's lives. There are many issues that can arise from incomplete coverage, insufficient quantity, not reapplying after washing the hands, for example, after having a dinner or eating something or having been to the toilet. Hot baths before application is to be discouraged as it renders or is likely to render the cream less effective. And treating only the affected person and not including the close contacts, sometimes either for the reason of embarrassment or being worried that they may, how their close contacts will handle the situation when they are told that they have come in contact with possible scabies. Oral treatment for scabies has become much more common. In the past year, I have prescribed more ivermectin than previous 20 years. Traditionally, we saw excellent results with topical therapy, and the need for oral medication was reserved for select cases. Ivermectin is indicated for severe resistant cases of scabies. It works by paralyzing the mite's nerves. The dosage is weight dependent at 200 micrograms per kilogram, typically given in two dosage on days 1 and 8. However, in some cases, especially during the pandemic, we have used extended regimens of ivermectin over 3 days, 5 days, or even 7 days to align with the mite's life cycle, which includes stages from eggs to nymphs to adults, via larva, of course. Side effects are generally mild, including possible dizziness, rash, and gastrointestinal issues. In fact, our experience with ivermectin has been it's a very well tolerated drug, and there were hardly any cases that I can recall where we had to discontinue the therapy or had to avoid using the second or other subsequent dosage because of side effects. A common concern is if housemates have been treated with permethrin and they have no symptoms, should they be treated with oral ivermectin? Current advice is that asymptomatic contacts can be treated with just a topical therapy. However, in exceptional cases, oral treatment may be considered to prevent reinfection. When patients start treatment for scabies, it's very important to let them know that it can take weeks before the symptoms completely resolve. And in fact, the symptoms can get worse in initial post-treatment period before they get better. This is what we call post-scabies syndrome, and in many patients, it can take for as long as good 6 months for this to resolve completely. It's a long time indeed, and in this period, patients often worry with slightest symptoms of itching or rash if the scabies has returned. One has to also be aware of other causes of rash and itching, including dermatitis from repeated use of topical scabies creams, inadequate treatment of scabies, and indeed treatment failure, possibility of reinfection from close contacts or new contacts or from their environment. Mite resistance has been a concern, but I believe most of the treatment failure is from uh, inadequate application and inadequate treatment of contacts. Patients who have gone through a pretty horrid time in terms of itching and rash, and particularly if they have got a history of psychological conditions in the past, are more prone to develop delusions of parasitosis. In such patients, we have to work together with them and address their concerns and help them move forward in life. And not to forget, uh, these patients may develop new skin condition which is not scabies in origin. Now let's look at the science behind the recommendations when it comes to care of the environment. The scabies might survival on different surfaces. Unlike many other infectious diseases, addressing the environmental source of contamination is crucial when treating bed bugs and scabies. On the skin surface, mites can last for 1 to 2 days. However, in bedding and clothing and furniture, they can survive up to 3 days. The reason they survive on the skin surface, and here I'm referring to them being on the surface rather than after they have burrowed, they lack nutrients and are affected by the host hygiene and inflammatory responses. So now let's have a look at how does the scabies mites behave at different temperatures. They do very well indeed at 37 degrees Celsius and can survive at the temperature in vitro outside the human body for about a week. When you look at temperature of 20 degrees Celsius, they can survive for 5 days, and at 0 degrees Celsius they can still survive for good 2 to 3 days. However, if the temperature goes up, they struggle, and at 50 degrees Celsius they will survive for perhaps few hours, and at even higher temperature than that they will die very quickly. Now let's look at the effect of humidity on scabies mites and how they survive at good 40 to 80 degree relative humidity. They survive for 4 to 5 days, but when the humidity is very low or very high, they don't fare that well. And low humidity of less than 20%, they don't survive for more than a day. So based on what the effect of temperature and humidity on the survival of scabies, the recommendations are based on how to take care of personal items. These are the four rules of care of the environment. Wash what you can, laundry at high temperature. Wash what you cannot wash. Don't forget your mobile phones, laptops, study chair, work table. Don't forget to quarantine what you cannot wash or wipe and seal them away for a week. In the past, there have been many studies where they have looked at the survival of mites in the environment for a day or two, and then there are studies where they have found that they could survive for 3 days, and there are some studies where they can say they can survive up to 7 days. So I reflected on this, and I can see that not all adult mites are the same. Some are young and youthful, whilst others are old. So their resilience to adverse physical conditions would be different. So to be safe these days, I advise seal away the content that you cannot wash or wipe for a week to be safe. Probably it's a bit of an overkill, but better it be that way than be complacent. And don't forget to hoover up the other items. And also, it's important to discard the hoover bag straight away rather than just hoover it and leave it in the corner for the mites to reinfect the environment. And finally, there are various disinfectant sprays available with anti-scabies, anti-mite agent like sumethrine, cypermethrin, and permethrin, and they can be sprayed on mattresses, textiles, and fabrics which cannot be washed, and the effect can last from good 2 weeks up to 12 weeks based on the choice of the agent. Scabies treatment is not only expensive but very time consuming and disruptive to patients' lives. It involves more than just applying cream. Patients must also manage logistics like removing and washing bedding and clothing and thoroughly cleaning the environment. This process must be done meticulously. I have had patients needing to reapply the cream because they forgot to treat items like shoes or socks. Attention to detail is crucial for effective treatment. In this section, I will go through some frequently asked questions from the patient. Although there is a lot of information available, so is a lot of misinformation uh, around on the internet. So let's go through some frequently asked questions. I can feel something crawling my skin. No, you cannot feel the mites crawling on you because they're very tiny and crawl very slowly. That's not to say that you're experiencing crawling sensation is not true, but it's not being caused by mites. How long can I have the symptoms of scabies without treatment? Many years. There are patients who have had undiagnosed and untreated scabies infection for as many as 7 years, and this is why it's called 7 years itch. Can mites jump off between people? No, scabies mites cannot fly. They lack wings and are designed to crawl slowly on the skin and burrow. They have strong legs to let them stick to skin surfaces. The primary mode of transmission is through direct skin to skin contact or indirect contact with contaminated items such as bedding, clothing, or furniture. Does soap kill scabies mites? No. Soap, detergents, or alcohol rubs do not kill scabies mites. They are designed to kill bacteria and viruses, but not mites. Do I need to treat my shoes? Yes. And if you may ask, I have got shoes, hundreds of them. What do I do with them? Well, at least treat the shoes you have been putting on in last 1 week. Will I ever get rid of this infection? Yes, the infection does go away with patience and treatment. You will win over mites eventually. Of course, you will. And here is some wonderful resource if you still have got time and energy to do further reading on scabies. And at this point, I must extend my gratitude to the following individuals for their contributions and support. Our dedicated healthcare team for their relentless efforts in treating and managing scabies cases and supporting them. The researchers and scientists whose invaluable work continues to advance our understanding and treatment of scabies. The patients for their patience and cooperation during their treatment journeys and teaching us invaluable lessons in scabies, some of which are not there in the books. Our administrative staff for ensuring seamless coordination and support, and finally, to everyone here today for your attention and commitment to improving scabies management. Thank you for watching and joining me on this journey to better understand scabies so we can provide improved care for our patients. Here is a link to a self assessment quiz that I have prepared to help you assess how much your understanding of scabies has improved. You can also leave your feedback and any comments or questions you may have. Thank you very much.